Welcome. Today we are going to talk about a theme that is very prevalent and can be quite complicated. That's anaphylaxis. And if you are a little bit older like me, you have seen these movies. It's Hitch and My Girl, and you have seen that even in the movies it's depicted as something that we have to worry about, and a lot of tears have been shed due to anaphylaxis. So, what is it? Firstly, it's a multisystemic syndrome. It's not just in one part of the body, it's all over because it's due the granulation of the mast cells. So we have the exposure to one antigen, the degranulation of the mast cells, and the release of histamines. And what the histamine makes? There are mainly two effects, that's H1 and H2. H1 is a very powerful bronchoconstrictor, so you have the airway closing. Also, the H2, you have the vasodilation, you have increased cell permeability and vein and vasal permeability. Also, you have the increase of the production of mucus. So you have an airway that's hyperreactive, so the diameter is reducing. You have the the augmentation of the production of secretions, and it all complicates the ventilation of the patient. There are also some other molecules involved in these reactions, like tryptase and nitric oxide, prostaglandins, but the main effects are due histamine. And why are we so worried about anaphylaxis? Pretty much because it tends to be very fast and very grave. So if it's an iatrogenic exposition, for instance, if you're making a medication that the patient is allergic to, from exposure to cardiac arrest, it takes in average 5 minutes. So it's very, very fast. If you're thinking about some bug bite like bees or something, it tends to be around 15 minutes from the exposure to the arrest. And if it's food ingestion, 30 minutes. But even so, it's very fast. That's why we worry so much about it. There are pretty much three ways to say, hey, this is an anaphylactic reaction. First, you would have skin or mucosal involvement with at least one of the following: either respiratory compromise or hypotension and organ dysfunction. So if the patient has any reaction like a rash or urticaria, pruritus, something like that, and one of the other, you already can say that this is an anaphylactic reaction. Either you may have a probable exposure, so the patient is unsure about if he is exposed or not to the antigen, and two or more of these four. So skin or mucosal involvement, respiratory impairment, hypotension or and organ dysfunction, and GI symptoms like cramps, vomiting. So if you have two of those and a probable exposure, so let's say the patient was in a restaurant and he doesn't really know what he ate, this could be an anaphylactic shock. And the third way is hypotension after a known trigger. So you can see this is very straightforward. So let's say the patient has a known allergy, for let's say for shrimps, he's allergic to shrimps, he has been exposed to it, and he has nothing else, just hypotension. That's enough to say this is anaphylaxis. So we have to intervene immediately in these patients. One thing that we have to be aware of is a patient that is already hypertense. So if his baseline is high, just a reduction of 30% is already hypotension. I don't need him like with a very low BP to say that this is hypotension. For him, it's already hypotension, and you can say this is anaphylaxis. So we have these three ways to say this is anaphylaxis. And the pitfalls that we have is a late recognition. So we are very used to say, hey, this is anaphylaxis when the patient has skin involvement. But we have seen that not all of these patients need it. So if we are waiting for it, we may be losing time. In about 10% of the patients, we will not have any skin impairment, especially if the patient is taking some antihistamines, so you can have even lower numbers. Another pitfall is asking for labs to confirmation. There's no need for that. We may ask, like, if you're in an academic environment, if you wanna register it, the plasmatic histamine or tryptase, but it's not. We don't use it for the diagnosis. So we these are our main pitfalls, and we have some red flags. The first is fast progression. So if you have a patient that has a very fast progression of his symptoms, we have to be very careful because he may go to arrest or something. So we have to be very aware. If the patient has already stridor, that means upper airway impairment. That's a very bad sign. On the other hand, if you are doing your auscultation and you pretty much don't listen any lung sounds, that's also very bad. That means that the airway obstruction is so severe that not even stridor or wheezing is happening anymore because you don't have enough air passing through the bronchus. So that's another sign of another red flag. If the patient has hypotension, shock, arrhythmias, also nausea and persistent vomiting are signs that this is not a very good patient, that we have to monitor this patient very closely. And how do we treat? The first we start treating this patient by removing the cause, if we can, obviously. If the patient has ingested some food, usually we cannot take it out. But if it's something on the skin, on the clothes, some kind of cutaneous exposition, we may be able to remove the cause. And our main pillar of the treatment is epinephrine. So these patients, if you say this patient has anaphylaxis, it's the same as saying this patient is going to receive epi. And we can usually start with IM epi, so 0.5 milligrams in the thigh. It's our we started. We can use IV if you already have IV and it's a patient with like a very bad case, but usually we go for intramuscular application of epi. Why? We have pretty much the three mechanisms involved in the epi that will work for these patients. So the alpha 1 receptors will do vasoconstrictions, as we have seen. Histamine is augmentates the permeability of the vases, so I want this. Also, the alpha 2 is ino and chronotropic, so will make my heart pump faster and better, and we have seen that these patients can evolve to hypotension and shock very quickly. And also the beta 2 effect will cause bronchodilation and reduction of the granulation of the mast cells. So that's why our first line is epi. Also, if the patient is hypotense, we start with volume. We can think about 20 cc's per kilo, but usually you go with smaller aliquotas and see how the patient is responding. And there are other ways to see if the patient is fluid responsiveness, but we can think about 20 milliliters per kilo. What about antihistamines? So, yeah, they don't work for anaphylaxis itself. All the things that we are worried that will kill this patient, that's hypotension and airway obstruction, the antihistamines won't work for it. Yeah, it will reduce the urticaria, the nose symptoms, like the runny nose and that kind of stuff, and nose pruritus, but it's not what I'm worried at this moment. So we should not delay epi to use some antihistamines. yeah, you can use it as parallel, but you cannot delay epi. The same goes for steroids. So yeah, they don't act fast enough, and they may delay epi again. So there are not very many cases when you use steroids. You may think like some patient that has a very bad case, some delayed reactions, patient that has already had a delayed reaction before, but we tend not to use it as first line treatment. And so we may have one thing that the steroids may act upon is the biphasic reaction. So about 5% of the patients will have um, the first anaphylactic reaction will get better, and 1 up to 12 hours, or sometimes some literature says up to a couple of days after, we'll have it again. Nobody really knows why it happens. Some say it's because of a second wave of degranulation, because of the drug metabolization, or maybe some erratic absorption of the antigen, but it may happen. And usually it's related to severe symptoms. So a patient that has come with a very bad case, he's at risk for having a biphasic reaction, and also it's associated with late or inadequate doses of epi. So that's why we have to insist on giving epi in the adequate dose and fast. Another kind of case that you have to worry about is patients that are using beta blocks. The epinephrine may not work as well as expected. So if you give epi a couple of times and the patient's not responding and is already on use of beta blocks, you may think about using glucagon for these patients. And how we manage these patients? So the airway, we have to treat the bronch spasm pretty much like any other bronch spasm, like COPD or asthma. We use nebulization or the inhalation of beta block and ipratropium, and we have to think like these two classes of drugs as Batman and Robin. If Batman is alone fighting the Joker, yeah, he can do his job quite well. But if Robin is with him, it's even better. They can beat the hell out of the Joker. But if Robin is trying to get the Joker alone, yeah, he won't do it. So that's why we need the association of the two classes of drugs. And if you can't not use the beta agonist. So always use it. And for some cases, also you may think about using magnesium sulfate and sometimes even nebulized adrenaline. And how do we, if we need to get an airway on this patient, how do we do it? So usually we go for some ETT, the endotracheal tube. What's the problem? We have a very hyperreactive airway and the diameter is already reduced. So we may have to use a smaller tube, and when we are doing our laryngoscopy, it may even worsen this edema. So you have to be already with your plan B at hand. Can we use supraglottic airways? No, in this case we cannot, because the airway obstruction tends to be uh, under the epiglottis. So my SGA will not work in this case. So my plan B will be a cric, sometimes even my plan A, but there is no room for SGA in these patients. And generally, we say to leave these patients in observation for 4 hours in mild cases, and up to 8 hours in patients with late reactions, with severe episodes, and use of beta blocks. Upon hospital discharge, we may consider leaving steroids and antihistamines for these patients. So it's not very well studied, but we may use it. It will alleviate some other symptoms for the patient. But we may think about using an auto-injector. So the epipens, the problem, they are pretty damn expensive. Like where I live here in Brazil, we don't have access to those, so there's no way for me to say to the patient, get one. Also, the price tag, even if they go to USA, for instance, and bring to Brazil, it's really expensive. So it's very hard for us to give this kind of orientation for our patients. But if you have it available, you should orientate your patient to have one and orientate the symptoms and when to use. So the patient must know the red flags. So he must know when he's having an anaphylactic episode and to go as soon as possible to seek medical care. Uh, PO drugs don't really work very well. At least for anaphylaxis, they don't work at all. They will, yeah, alleviate some of the symptoms like the urticaria and that stuff, but the patient must be aware that he may have another anaphylactic reaction and that has to be treated with epi. So either he has his EpiPen or whatever, or he needs to go to a place that can give that kind of medication to him. Also, you can orientate this patient to search for allergologist ambulatory in an outpatient way, so he can know what is his trigger. There are many triggers, so this must be investigated in the out of patient out of a hospital, so you have time for that. Usually, the cutaneous testing for allergic for triggers is done 1 to 4 weeks after the anaphylactic episode, because you still have the mast cells they have degranulated, so the the reaction may not be as positive as you expect, so you may have false negatives on this exam if you do it just after the anaphylactic episode. So just to for us to sum up and see how bad an anaphylactic case can be, this is one case where we were called for a male around 30 years old that was in a cardiac arrest. They didn't give us much more information, and the ambulance was dispatched. Upon arrival, we had a firefighter ambulance crew already doing CPR with BLS. The patient had arrested around 15 minutes before the first crew arrived, and when we, the ALS crew, arrived, it was around 25 minutes after the episode, so around 10 minutes after the initiation of BLS. The patient was in asystole, so when we are thinking about an anaphylactic case, we have to think about the 5H, 5T, and why this patient has arrested. And pretty much the main reasons for these patients arresting is hypoxia for airway obstruction and hypovolemia, because you have this venodilation, the augmentation of permeability, loss of fluids to third space. So these are the main reasons why this patient may arrest. And the laryngoscopy, you could see this, a very swollen epiglottis. There was no way to see the trachea. Usually what we try to see is like this epiglottis, very nice, the vocal folds, and the trachea itself. But in these cases, if you have a lot of edema, the swollen epiglottis, you pretty much don't see anything. It's very hard. It's a very hard intubation. If you're thinking about the Cormack-Lehan classification, we have uh, the first degree up to the fourth degree. It's somewhat similar to the Malampati scale, but this is upon laryngoscopy. So if you see everything, it's first degree. If you see more than 50%, it's second. less than 50, it's third, and if you don't see anything of the trachea, it's fourth degree. What's the problem? If you have fourth degree, we cannot even use bougie. The bougie needs to, you need direct visualization of at least a portion of the trachea to be able to use the bougie. And in this case, we couldn't see anything. So it was opted to go for a crike. This patient needed a crike to get an airway in. So that's what we did. And after talking with the dispatcher, the story is as goes. The patient himself called the 911. For us is 192 here. So he was on the phone complaining of sudden shortness of breath. He already had a hoarseness on the call, and during the call, the patient stopped talking, and the dispatcher heard the phone falling on the ground, and the patient was mute. So probably the patient arrested at this moment, and both ambulances were activated. The patient had no known diseases or allergies, but there was a story of possible drug use according to the family. Unfortunately, due to the long time this patient was in hypoxia, so until the moment we were able to get a criking, it was over 25 minutes of hypoxia, and this patient fatally evolved to death. So the anaphylactic reactions can really kill patients in real life. That's why we worry so much, and we have to recognize the first symptoms, and we cannot delay the use of epi. If you have any feedback, any questions, uh, anything, if you wanna drop a line, you can use the comments below or just head on Instagram and say hi, and I see you next time.